So Mohs micrographic surgery, it's a type of surgery that we generally use for more high-risk skin cancer or skin cancer that's located in more high-risk areas such as the face, the neck, anywhere I kind of think about as being an area where we're trying to preserve as much healthy tissue. We're able to get a 99% cure rate for basal cell skin cancer and 97% cure rate for squamous cell skin cancer. And these are the most common forms of non-melanoma skin cancer. There's kind of atypical or more obscure skin cancers that we will also treat. Generally, it's the ones that tend to have not an invasive component, so the ones that we call in situ or limited to the upper layer of the skin. It's all done in an outpatient setting and done under local anesthesia. So they come in, they get roomed, and then we'll just cut right around the area that was delineated. They'll wait around for an hour to an hour and a half while that tissue is being processed, and then I'm able to get my pathology read as well. If I see a positive margin, then I keep going back until we get rid of the thing. What we will do is we draw around where we see clinical skin cancer. The way I make the incision, or I guess excise the lesion there, is in a special what we call beveled manner, so kind of angled. I will then take it to my lab histotechnician, and we make scores both on the tissue and on the patient that allows us to translate what I took off into a map. So she turns that into slides for me to read. As a Mohs surgeon, you're both the surgeon and the pathologist. So I do the cutting and I do the examination of the pathology slides. And it allows us to look at 100% of the margins, which you don't normally get with an excision. When we're actually doing a conventional excision, we're really only seeing about 1% of the margin compared to the 100% of the margins that we can see with Mohs surgery. And that's why Mohs surgery has a higher cure rate than a standard excision. We're able to look at all the sides as well as the base to make sure that there's no skin cancer going outward or deeper. And if there is, we're able to map out exactly where that root is. We can go back and just take back where there's still a positive margin, so we don't have to keep making concentric larger and larger circles that you might otherwise have to do with a conventional excision. So the goal here is that we can get rid of the skin cancer with 99% accuracy in the case of basal cell skin cancer and 97% in the case of squamous cell skin cancer, but also save as much healthy skin. Most pain is controlled with just over-the-counter Tylenol or ibuprofen. There's not many complications, and patients tend to tolerate the procedure quite well. If you have a spot that you're worried about, it's important to get in with a dermatologist, or if it's a primary care physician that's comfortable doing a biopsy. Generally, when patients have a positive skin cancer biopsy from their primary care physician, it's generally kind of referred to our dermatologist pool, and we kind of get a good idea of A, if it's an appropriate treatment, or B, can it be treated with something potentially a little less invasive.